on the call. Thank you, Gerondy, for remembering that. My name is Zachary Goldman. I'm a health economist on the Oregon Health Authority team, specifically the Cost Growth Target team. Today's meeting is about the Sustainable Healthcare Cost Growth Target Program. This is meeting number 1 of the Rules Advisory Committee. So again, thank you all for your time. Thank you for being here. I think this will be a good discussion, and we look forward to hearing a lot of everyone's input. More folks are coming in, and that's okay. We'll start with kind of the housekeeping stuff. Gerondy, will you please go to the next slide? Okay, so for some Rules Advisory Committee meetings, and some of you may be new as the first time Rules Advisory Committee member, typically what happens is we do a roll call, and I'll ask everyone's name and are you present or not. We have over 40 Rules Advisory Committee members, which is amazing that we have that much engagement. But that's going to take a lot of time, and we'd rather dedicate that time to discussion and sharing thoughts both ways. So here's my ask of you. For Rules Advisory Committee members who are present, do me a favor and open up the chat feature on Zoom and just put your name in there. And you can send it to everyone. You can send it to just me. But just put it in there so that way it's kind of on the record that you're here, present and accounted for. So everyone's chats now are going to light up, and that's okay. Everyone's names are coming in. I see them. So that's great. Thank you so much. We are recording. So FYI, thank you, Gerondy, for doing that. And let's go to the next slide, please. Let me cover at a high level what we're going to talk about today. First, we're going to start at a really high level of introducing rulemaking. There is, if you haven't seen it yet, I encourage you to do so maybe after this meeting. Check out the rulemaking fact sheet, and we have the link right there. It's posted on the accountability page, and I'll put that in the chat too shortly. That document just kind of lists out what's the overall high-level purpose of a RAC. It includes the specific organizations that are represented at this particular Rules Advisory Committee meeting. So it's just a good kind of introduction, particularly if it's your first time. It's a nice introduction to what rulemaking is. If you have any technical assistance, if you're trying to talk, you're trying to raise your hand, you're trying to chat, but you can't figure it out. If you can chat, send a chat to Gerondy. Gerondy Weatherspoon is the wizard behind the screen here. She's operating the slides and a really great resource. If you can't do the chat, but you want to, just either raise your hand, or if you can't do that, just unmute yourself and chime in. So we want to hear from you. If you're having technical difficulties, please let us know. So we're going to talk a little about the rulemaking fact sheet, but not a lot. Mostly, we're going to launch into a brief presentation on introducing accountability. So we want to kind of set the stage here about what we're going to talk about. And then we're going to introduce some rule, division, chapter, and proposed structure on the rules. And then the meat of the meeting today is to talk about a draft document about reasonableness. And what does it mean to have reasonable cost growth above the target? So that's going to be the bulk of the conversation. We're going to solicit input. That document, if you want to skim it, or if you haven't yet, is linked there. And then at the very end, we're going to open up to public comment. Okay, let's go to the next slide, please. Quick introduction to the RAC process. Again, we have a lot more detail on the fact sheet, but at a high level, RACs are used to seek input to the maximum extent possible during the development of proposed rules, prior to giving notice of intent to adopt, amend, or repeal an administrative rule. For our purposes, we're both amending rules and adopting brand new rules, because we have whole new kind of chapters, whole new sections of rules that we have to do. RACs allow the public and interested parties to provide input and suggestions during this development of new rules, or amending rules or repealing rules, although we're not repealing rules for this time. And the fiscal impact of that rulemaking. So that's an important piece. The RAC's role is advisory. Consensus is not necessary. There's not a formal vote. This is all to solicit input. Many people can agree on a given point of input. Folks can disagree on a given point of input. The intention here is to gather as much input as possible from all of you parties and individuals. OHA is holding these racks as public meetings, so any individual is welcome to attend, observe and listen, and we will record and post the meeting in its complete duration, and then at the very end, as I mentioned, there will be some time for public comment. Okay, let's go to the next slide, please. Great. So let me talk about the timeline. And then I want to talk about kind of, given how many folks there are here, kind of some suggestions. So at a high level, the arc here, the first RAC meeting is today. February, we're gonna have the second. March, we're gonna have a third. April is a fourth. So we're slotting 4 RAC meetings, which is frankly a lot compared to other programs typically. But this is a big program. We know a lot of folks are engaged and interested, and we want to create that space. And in May, the hope is that we have the official rules hearing in May. And if folks have questions about what is a rules hearing, we can cover that when we get a little closer. Let's go to the next slide. So a little more kind of in depth, what are we talking about at those meetings? So today we're doing a quick orientation on what is the scope of a RAC. Then we're going to jump into a discussion of draft criteria for assessing when an entity's cost growth over the target is deemed reasonable. In February, for our second meeting, we're going to continue that same conversation about that reasonableness conversation. But then we want to discuss performance improvement plans, or PIPs, as they're known. For March, we want to jump into financial penalties. And April, we'll probably need to continue that discussion on financial penalties. So we're slotting in 2 meetings. There'll likely be some spillover. So for example, we'll have a good discussion on PIPs in February. There'll likely be some spillover in March about PIPs, and that's okay. So that it's okay to spill over into another meeting. Let's hang on this slide for a second, because I want to talk about the fact that because there are so many RAC members, as I said, more than 40, the most efficient use of these meetings is to ensure that all questions are answered, kind of on the technicalities, like the components of the program, the specifics that we're proposing. We want to make sure that everything's really clear. We welcome all RAC members' thoughts during the meeting, but there may not be enough time for every RAC member to provide input on every sentence or every clause in the rules. We're going to try to create as much time as possible, but we also want to highly encourage RAC members to submit input in writing. We think that's going to allow for kind of the most conducive, kind of get all the points out there. We'll post all of those comments on the website, so everything is there. This recording of the meeting will be there. If you want to submit it via email, we can put the email. If you want to do it on letterhead or a Word document, we can take that. Kind of whatever is helpful, we want to take that. Any written comment is just as valuable and worthy as a verbal comment shared in the meeting. So given that there's so many of us, we strongly encourage folks to submit comments in writing. And of course, we're going to hear folks verbally too at the meeting. So just want to put that out there. Okay. Also, one more point. If you do have a question or a comment, feel free to use the chat function too. We've opened that up to everyone, so everyone can use that, hopefully. Sarah and I will try to address specific questions that are raised in the chat on the fly. We'll try to do that. Of course, feel free to vocalize that question or put it in chat. Essentially, no wrong door when it comes to questions or input. That's the name of the game there. Okay, let's go to the next slide, please. I want to chat a little bit about what is not in scope for this RAC. So what the cost growth target program is measuring is not in scope. How performance relative to the cost growth target is calculated, kind of the methodology, the mechanics of it, that's out of scope. Which payers and provider orgs are subject to the cost growth target program, that's already codified and specified. And lastly, which accountability measures are part of the program. As you'll see, we're going to be referencing statute in a lot of ways in these RACs, in these meetings. So we're kind of grounded in what the statute says. Many components of the program are already solidified. The data submission process, things like that. So some of it is kind of baked, as it were, but some accountability measures are not fully baked, and that's what we're talking about during these RAC processes. Let me pause here for a moment because next we're going to go into an introduction to Oregon's Sustainable Healthcare Cost Growth Target Program, just a quick intro. But let me see if folks have kind of technical questions or procedural questions or anything of the like. Okay, not seeing any, which is great. Something comes up, put it in chat. Feel free to raise your hand. And with that, I think let's move on. Let me introduce Sarah Bartleman, and she'll talk a little bit about the program and kind of how we got here a little bit and accountability.
Thanks, Zachary. Hi, everyone. I'm Sarah Bartleman. I manage the Cost Growth Target Program here at OHA. And I know many of you, I'm really happy to see so many of you participating in the RAC. And much of this is probably familiar. We've presented on the history of the Cost Growth Target Program a lot. But we want to just make sure everyone is starting out in this rulemaking process from the same page. So I'm going to give just a couple of sort of framing remarks to get us started. Next slide, please. So some of you may have seen these slides or other similar data points floating around out there, but this is to sort of take us back to where we were as a state and where the conversation was in about 2017. So we knew that US healthcare costs were higher than other countries. Oregon was experiencing some of the fastest healthcare spending growth in the country. Healthcare costs were growing faster than income. People in Oregon were paying the highest deductible, some of the highest deductibles in the country. Our prices were higher than national, and people were really struggling with healthcare costs. And so the legislature created a joint task force in 2017 to look at healthcare costs and healthcare affordability and what we should do about that. And so all of our work is really stemming from that context and that initial legislative task force. That task force was originally charged with studying Maryland's global hospital budget model, which they ultimately decided was not the right path for Oregon and set us on this cost growth target path instead. Next slide. We know that affordability challenges are still very real for people in Oregon. People with health insurance can't afford to use it. Just one statistic here is that between almost 30 and 45% of people in Oregon would be considered underinsured. So those are people who have insurance, but for whatever reason, they can't use it or they believe they can't afford to use it. Their out-of-pocket costs or their deductible costs might be just so high compared to their income that they're still facing barriers to getting the care that they need. Next slide. And we know from a survey of consumer experience of healthcare in Oregon, about a third of adults in Oregon said that they skipped needed dental care, delayed going to a doctor and getting a procedure, or avoided care due to costs. 1 in 4 adults said that they skipped doses of medicine or did not fill a prescription. So even though we've been talking about this program and talking about costs and healthcare affordability in the state for a long time and working on standing it up with a pretty long timeline, and I'll talk about that in a second, these affordability challenges are still very real. When we held our cost growth target public hearing last year, we heard a lot from consumers. All of us are also consumers of the healthcare system, and we all have our own healthcare experiences, either personally or friends and family. And so we really, in all of the work that we're doing with this cost growth target program, we are working to keep that affordability component and the impact that healthcare costs are having on people at the forefront. Next slide. So the cost growth target program has an annual cycle, and the wheel here on the slide describes that cycle. Every year, the program collects data, measures healthcare spending, healthcare cost growth relative to the cost growth target in a bunch of different ways, does some analysis to understand what the key cost growth drivers are, what the experience is in each market, Medicaid versus Medicare versus commercial, what's happening by service category, hospital versus pharmacy versus professional services, and more. That all culminates in an annual report and public hearing, really bringing transparency to understand what is happening in Oregon, what that experience looks like. Last year, 2023, we had our first public report that included health plan and provider organization level performance. And we really started focusing on the payer and provider experience at our public hearing last September. Ultimately, just setting a cost growth target is not going to do anything about cost growth by itself. Just sort of recognizing the cost growth target is just a number. And really, it's all of this other work that is happening. It's the analysis, it's the transparency, and then it's using that information in those conversations to really identify and implement additional strategies to mitigate what those cost growth drivers are or to help address whatever's coming up. The accountability measures for the cost growth target program are part of that. They're part of that motivation for that. But ultimately, at the end of the day, the program is just a program. It's just a number. And without those actions, without those strategies and the implementation of those strategies, we cannot reasonably expect that healthcare costs will become more affordable in the state. Next. And then the last thing I want to say about the context and the history here is that the cost growth target program has a very long ramp up, and that's by design. That is to allow time for change. And when the program was first, we were first having some of our design conversations. We were first talking about when different components of the program would roll out. We heard very loud and clear in our implementation committee that it's not easy to change the system. It's not easy to turn the ship. And when we think about things like multi-year or contracts between payers and providers that are negotiated on a multi-year period, it's not as easy as just saying, all right, starting in January, all costs will be capped. And so we have this deliberately long implementation phase where different components of the program are added on over time. So our first 2 years, we only reported data at the state level. Starting last year, we then began reporting at the payer and provider level. So that's the 2023 public reporting begins. We had our first public hearing on performance. And then our accountability measures, what we're going to spend the rest of the meeting talking about, don't roll out for a few more years. Performance improvement plans begin in 2025 and financial penalties begin in 2027 at the earliest. So there are lots of mitigating factors, lots of reasonable, good reasons for cost growth. And we're going to talk more about that later today too. But just wanting to flag that this was all sort of very deliberately designed from the beginning to have that long timeline so that payers and providers, other partners, other mechanisms and levers to address healthcare costs would have time, that there would be time to put these things in place and time to work to meet the cost growth target before any of the accountability kicked in. And I will stop there and see if there are any quick questions about the history of the program or the timeline.
Sarah, hi. Can you hear me?
Yeah, go ahead, Tim.
So I'm Tim Powell. I'm a family physician in Roseburg. I apologize for coming in late. For whatever it's worth, I'm probably the only one. I really had to search for the link to find. This is my first meeting, and maybe there's a special password or hand signal that I didn't know about. But I did really. I finally found it under accountability, but under the usual link. So when I came on, Mr. Goldman, Zachary, you were speaking, and I just heard the word repeatedly out of scope. And how I interpreted is that's not what you guys are being asked to address here. And I assume we're here because there's something the OHA does want our input on. I hope that's true. Would you mind helping clarify for me what it is that this committee is about?
Yeah, happy to. Thanks for that, Tim, and thanks for highlighting.
The link was hard to find. We will rectify that for future meetings and make sure that that link is up front and center for folks for convenience. So what are we focusing on? Not so much what's out of scope, what's in scope. So what's in scope for this meeting, we're specifically going to talk about the different causes, the reasonable causes of cost growth that exceed the target. That's what today is about. Next month, we'll continue that discussion, but then switch gears a little bit to performance improvement plans, or PIPs as they're known. And then for the subsequent 2 meetings, so for March and April, we'll talk about the financial penalties, the ultimate accountability mechanism.
And we're going to talk, we're going to provide a little bit more context for all of that and how it fits in the program in the next couple minutes. So hopefully that will help with what we are teeing up the conversation for.
Thank you.
Yeah, no, thank you. Joni, let's move to the next slide for
entities. And while we're moving to the next slide, if folks haven't yet, please be sure to put your name in the chat if you're a Rules Advisory Committee member, just so we have a record of you being here. And of course, if you have any questions or anything, feel free, like Tim did, raise your hand, chime in, or add questions to the chat. Okay, so let's talk about accountable entities. Let's go to the next slide, please, Charlie. So let's talk about kind of who is part of this program and specifically who might not be. So for payers, because there's two different entity types, payers and provider organizations. So for payers, payers and TPAs, third-party administrators, with at least 1,000 covered lives in Oregon must submit cost growth target data each year to the Oregon Health Authority. Payers and TPAs with at least 5,000 lives in a single market. By market, I mean Medicaid market, OHP, Medicare Advantage, or commercial. If you have 5,000 lives in one of those markets, then you'll be measured relative to the target, reported publicly, and subject to the accountability measures if applicable. So that's payers. For provider organizations, there's kind of the two conditions that have to be met. So provider organizations are measured relative to the target, reported publicly and potentially subject to accountability measures, but only if they include primary care providers who direct the patient's care and have at least 5,000 attributed patients in a single market. And again, by market, I mean Medicaid, OHP, Medicare Advantage, or commercial. So if you're a provider organization that doesn't have any primary care providers, then you wouldn't be subject to it. If you're a provider organization that maybe only does cardiology, you're a group cardiologist, or only physical therapists, or only dermatology, then you wouldn't be subject to this program. So that's kind of the lay of the land in terms of who is included and what entity types are included. Yeah, Eric, go ahead.
I think a really good question is primary care is who direct a patient's care. Can you describe the difference between a primary care physician who doesn't direct patient care and one that does?
Yeah, so we just wanted to add a little more kind of color to what a primary care provider is, to kind of define a primary care provider as someone who directs patients' care. Sarah, did you have thoughts about that? I saw you come off mute.
Yeah, there is not a distinction for the purposes of this program between a primary care provider who directs a patient care and a primary care provider who does not. There is an assumption that primary care providers play a role in directing patient care writ large.
Okay, thanks.
Yeah, good question. Okay, let's go to the next slide, please, Jerome. So here we have a list of the payers subject to the cost growth target last year, 2023. So if you work for or are representing a payer or carrier and you see your name, hopefully it's not a surprise to you. But here are the list of payers subject to the target in 23. It's possible that that there's some change year over year if a carrier gets larger or smaller, right? If it kind of goes under that 5,000 lives. Similar to providers, I suppose, provider organizations, if their attribution number is greatly increasing or greatly decreasing, there may be times when you're not subject to it if the numbers go below the threshold. So this is the 2023 payers that are subject to the target. Let's go to the next slide. For provider orgs, there are more of them, so the font's a little smaller, but hopefully you can read it. And again, some of you are probably representing some of these entities, and we're glad you're here.
And
if there are any questions, oh yeah, go ahead.
Sorry, Zachary. I see that Peter has a question in the chat, and I want to redirect a little bit. I think, Peter, I'd be happy to talk about the inclusion exclusion offline, but I think when we were saying that was out of scope, I'm saying that's sort of not open for change at this point or through this rulemaking advisory committee. So I'm happy to connect with you offline to talk more about the design elements there.
Thank you.
Great. Are there anyone?
From an organization who you could have sworn you were subject to the target, but you're not seeing your name, or the converse, that you see your name, but you're pretty sure you're not. Like, do we need any kind of clarifying questions on that front? I'm guessing not. Okay. Okay, great. Johnny, let's go to the next slide. And I'm going to pass it over to Sarah here to talk a little bit about kind of what does accountability mean kind of writ large for this program. And we'll end that mini conversation as to, okay, where do we go from here, and what pieces do we need to develop further? And that's what the conversation is about today.
Thanks. Okay, next slide. So we are focusing on the accountability portion of every year's cost growth target measurement, reporting, and accountability. And when we say accountability or accountability mechanisms, we really are talking about three different things. And we sort of three layers of this. And the first is transparency. So that is the public reporting and the public hearings I mentioned. Those payers and provider organizations that Zachary just talked about all have their cost growth measured and reported on by name. There's a little bit of that name and shame happening as part of that first layer of transparency. And transparency is really a core component of the program, and is something that is shared by all states that have a cost growth target body of work. The second accountability mechanism is a performance improvement plan. So this is designed to be the first thing that happens when a payer or provider organization exceeds the cost growth target with statistical certainty and without good reason. And there's a lot of parts of that statement. So the reminders here on the side of the slide are only payers and providers that exceed the cost growth target with statistical certainty are subject to being held, or would be held accountable. So as part of our calculations and reporting, we determine whether or not a payer or provider organization has exceeded the cost growth target with statistical certainty. We have a whole methodology. We're happy to share links, talk more about that development. But basically, the short story is we will say a payer or a provider has met the cost growth target, has not met the cost growth target, or is indeterminate. So there can be a lot of noise in the data, especially for smaller organizations that are, closer to that 5,000 live threshold, or that maybe have a high cost patient that sort of just changes, results in a lot of bouncing around in the data year to year. We will sort of account for that in that statistical process. So only if the cost growth target has been exceeded with statistical certainty. And then the second part of that complicated sentence is without good reason. And again, that is what we're really just setting up the stage for, to talk about what are those good reasons, how do we determine if it's a good reason or not a good reason. So the intent is that there is a whole process. I like to think about it as a funnel where we say, all right, payer or provider in the program at the top of the funnel, cost growth was met, not met, indeterminate. That's going to narrow it down even further. With statistical certainty, narrows it down even further. Without a good reason, narrows it down even further. We know that there are lots of good reasons for cost growth, and we're going to talk a lot about them today. That's what the whole determining reasonableness is about. And so we're really talking about at the bottom of the funnel, after all of those things have happened, then if there is statistically significant cost growth above the target without a good reason, there would be a performance improvement plan. That will be the topic for our second rack. We'll talk more about how the performance improvement plan process will work and how we're envisioning that whole cycle. Performance improvement plans are also shared by a number of other states that have cost growth target programs. Massachusetts is our sort of the first state that has actually put an entity on a performance improvement plan, and we have that as an example. The third and final accountability mechanism we have is a financial penalty. And this is for payers and provider organizations who exceed the cost growth target with statistical certainty without a good reason for multiple years. So this is our sort of repeat offender. So without good reason, continuous every year or multiple years in that 5-year period, this payer or provider organization has high cost growth and it's not justified. And so then there's financial penalty. This is in statute. Zachary mentioned that we'd be referencing sort of what's up for debate and what isn't. These mechanisms are in statute. We can't come out of this RAC process and say, actually, financial penalties are a terrible idea. They should go away. They're in statute and we're figuring out how to operationalize them. We will talk more about that in our third and fourth RAC meetings, and we'll get into the details of the methodology, how the financial penalty is calculated, what goes into that. But this is the overview. And I think the last thing I want to say about these mechanisms is some of the legislative intent behind making sure that Oregon had both the PIPs and the penalties. The legislature was concerned that if we only had PIPs, if our program looked like Massachusetts, which only has PIPs at this point, that we might be afraid to use it, that it would be a really big hammer and that it wouldn't be designed to support that continuous improvement. And so that's why we have what we think about as these escalating mechanisms. So performance improvement plans are really an opportunity to work on what those key cost growth drivers are and help an organization get to meeting the cost growth target in the future. And then we have financial penalties down the road for, again, sort of that repeat overage. Eric, you have a question.
Just a quick clarification. So you, on the side, it says only payers and providers that exceed with statistical certainty and without good cause will be held accountable. And you list transparency, PIPs, and financial penalties as the accountability measures. Is that to say that if a provider does not have statistical certainty, or if they do not have good reason, I mean, or if they don't meet statistical certainty, or they have good reason, they will not be transparent?
No, that's fair. That's a little misleading. I think transparency applies across the board. And we'll talk, part of what we're thinking about this year as we think about our public reporting is if there's a good reason or not a good reason, how do we share that as part of the public reporting and how much detail do we go into? But transparency is sort of no matter what.
Thank you, Sarah, for the clarification.
Okay, next slide. I want to just give a high level list at this point because we're going to talk about it more in detail as well, of the good reasons for exceeding the cost growth target. So this was a list that started back with our implementation committee in 2019 and 2020, starting to think about all of the reasons why an organization might experience cost growth above the target and recognizing that sometimes there are good reasons and we want to be seeing costs go up. And in no way is this program intended or hopefully will not see any of those unintended outcomes where we're resulting in changes or impacting access to care because of fears about cost growth. So for example, a couple things on this list. If there are changes in federal or state law, so state comes in and mandates that a new treatment has to be covered by all commercial insurance plans in the state. That is something that is outside of a payer's control. They now have to do that by law. That is a good reason. New treatments entering the market, new drugs entering the market. We know when we were originally talking about this, we talked about the Hep C drugs a lot and the cost impact that they had on the system. Now, the conversation, we're talking about the GLP-1 weight loss drugs and the anticipated impact that they are going to have on healthcare costs across the system. Acts of God, this is sort of our insurance terminology for pandemics, natural disasters, other things that we might not have anticipated and are also outside of the control of a payer or provider. Investments to improve population health and health equity. This includes things like investments in primary care and behavioral health. We know that there are areas of significant underinvestment in this state and that there are efforts to correct that. And so if those are the reasons why a payer or provider organization is seeing cost growth above the target, those are good reasons and we don't want anyone penalized for that. Macroeconomic factors, frontline workforce costs, et cetera. We're going to talk more about what's on that list and how it changes, but just a couple of quick questions I see from Vince. The good reasons are partially in statute. We are looking at codifying them partially in rule, but we also want to keep them flexible because additional reasons can be added. Things change and come up. And if my go-to example that I've said to you probably collectively a lot of times is if we had written this list in 2019, we wouldn't have put COVID on it. And so the list has to have flexibility. And one of the things that we're committing to in our draft rule and draft sub-regulatory guidance is that this list would only ever be additive. OHA would never come in and take something off the list and say, nope, that's no longer a good reason. So we might add new reasons in the future and we'd update all these documents, but that we wouldn't somehow pull the rug out from anyone once something was on the list. We do want to talk to you, and part of where we're looking for public comment today is what else should be on this list. and I'm gonna go through the guidance document in a little bit more detail in a bit, but I think I'm seeing some comments in the chat already about what about, and I think those are exactly the kinds of comments that we'd like to hear from you to make sure that we're really thinking about this list in a broad and expansive way, but also a realistic way. There are things that are something that a payer and provider does potentially have control over, and part of our charge here in rulemaking is to find the right balance. Okay, last slide real quick, Durandi. I just want to show again the timeline. This is another way to look at that phased in program approach. So this table shows the years of the cost growth target program, including the measurement period, the years of data that we're collecting, when we collect the data, when we report the data, and then highlighted in orange are those 3 accountability measures. So public reporting started in 2023, PIPs will start in 2025 at the soonest, and financial penalties in 2027 at the soonest. Okay, I'm just skipping the questions really quick before I hand it back to Zachary. Okay, I'm seeing some questions about changing the target number itself. So right now the cost growth target is at 3.4%. The good reason conversation is not currently designed to change the target value. The target value setting is the responsibility of the Cost Growth Target Advisory Committee, and that is their under their jurisdiction. So it might, I think the way that I envision this interplaying is if we go through this, we start going through this process where we're talking to the payers and providers and said, hey, it looks like for 2026, you exceeded the cost growth target. Why? And then we find out in this conversation that there were some of those factors that were really macroeconomic or changes in state or federal law, really something that would be broadly applicable. It sort of affects the whole system. We are holding, and you'll see this in our draft rule, essentially the ability to make a blanket determination and say, this was so disruptive, this was so whatever, that nobody will be held accountable for this measurement period. So we might do that across the board if there are some of those factors. So hopefully that sort of is the meat in the middle between the cost growth target committee changing the target and the determining good reasons individually. Okay, Zachary, back to you.
Yeah, thanks. And there's a lot of really great questions coming in. Keep them coming. Those are great. Just to kind of talk about a theme here for a moment. I'm seeing questions about what about existing expensive medications? Maybe they're not new, but they're existing. What about frontline workforce costs? What about kind of other potential kind of new costs? Great. Keep those questions coming. I think a lot of those questions will be answered when we get into the sub-regulatory guidance document that Sarah and I will walk through, that lists those kind of reasonable causes and goes into a little more detail. Excellent. Okay, Durandi, let's go to the next slide. Let's talk about the rules for a moment. Let's go to the next one. So at a kind of a high level, Division 65, that's just like the section of the rules that we're talking about. I want to look at the left-hand column for a moment. So and for folks maybe not as used to reading rules, sometimes they kind of have their own language, they sort of have their own structure. Typically the first rule 0000 is the general purpose of the program. Then the next one is just broad definitions of terms that are used in subsequent sections here. So that's what we have here. For the next one, we have general reporting requirements, and then we have a bunch of data submission things. So data submission requirements, waivers, compliance and enforcement, and then contested case hearings. So that's kind of the left side. On the right side, we have, it's a slightly different kind of topic, if you will, all related, it's all the program, but we have more data access disclosure, and then we have reasonable causes of growth. That's what we're talking about right now. And then we have performance improvement plans. Then we have cost growth target financial penalties, and then contested case hearings, and then we end it with annual hearings. This is the broad macro structure of the rules for the Sustainable Healthcare Cost Growth Target Program. Durandi, let's go to the next slide. Today, we're specifically talking about 0035, so 409, 065, 0035, reasonable causes of cost growth. It's kind of hard to read that bubble, but that essentially says reasonable causes of cost growth will include the rule for implementing House Bill 2045. Someone mentioned it in the chat. How do you deal with the frontline workers compensation? That was a bill last session, that was passed and the governor signed. So we're gonna talk about that, and that is included in 3.5, because that would be deemed a reasonable cause of exceeding the cost growth target. So this is kind of a bit of a roadmap of kind of where we're gonna go. Right now, we're talking about reasonable causes of growth. Next one, we're gonna talk about PIPs, as well as some of the other kind of, they're important rules, but they're not as kind of novel as reasonableness, performance improvement plans, and financial penalties. So broadly, we're talking about those three main pieces of the rule, but we're going to touch on the other things too. We make some changes to definitions, for example, to add some new terms that we're using in these sections. So we'll cover all those for sure, but we're going to put a lot of the focus on these. Any questions about kind of the rules, you know, where to look for the rules, where to find them, anything like that? Okay. This is great. Keep the questions coming. Yeah, so some questions about kind of what are these reasons, newly mandated benefits, for example, how would the savings be taken into account? Yeah, so we're going to talk about that in a few minutes. Yeah, so I was going to talk about 2045. Great.
Yeah,
Yeah, go
I
ahead.
think all the questions are probably in this next section.
Yeah.
So
Yeah.
bear with us, please.
Yeah, we're getting that. All right, Charlie, we go to the next slide, please. So now we're going to go into a sub-regulatory guidance document. Now, the link to this document is on that same accountability page that I think Sarah put in a link for. I'm gonna add it while Sarah's queuing this up. So let me pass it to her.
Thanks. Okay, so some of you who have participated in rulemaking committees before, this is going to be a little bit different. Usually you'd start by going through the rule language line by line, and we're not going to do that today. We're actually going to go right to the sub-regulatory guidance, which matches the draft rule language, but the sub-regulatory guidance explains a lot more about how we envision this process working, gives more detailed examples. And so we want to walk through the sub-regulatory guidance because we think it's going to really answer a lot of the questions, but as we get your input and your questions, and as we make edits, we will tighten up the regulatory guidance, sub-regulatory guidance, and the rules so that they match. So just wanted to sort of preface with, that's what we're starting with, and I think we want to spend the rest of the time talking about what's in this sub-regulatory guidance document. Just know that it's also in the draft rules, but we're not focusing on the rule language because it's a little higher level, and you're already asking all the detailed questions. So, okay, next slide. In this guidance document, this document is intended to provide more information, basically our operational manual for a lot of things. So that includes what are the acceptable reasons for exceeding the cost growth target. So building out that list that we previewed a few slides ago, defining all of those reasons. So what does it actually mean to invest in population health? What's sort of included in that umbrella or excluded? So the draft guidance includes all of that. We also spell out how the process works. So when does it happen? Who does it happen with? Where, who needs to be involved? What documentation is included? And then this is something that we've been talking to some of you about individually over the last couple months. And there's been a lot of interest, and I think a very understandable desire for essentially a formula, a very clear roadmap of, if I want to claim this reason for my cost growth and I want OHA to deem it reasonable, what do I have to do to prove it? And so we are attempting to lay out a series of questions. So for each good reason, we're laying out potential questions that we might ask that an organization, a payer, or provider could be prepared to answer. And then potential analyses and information. And I say potential for both of these, and I'll get into a more concrete example, but this is going to vary. The experience is going to vary between payers and providers, depending on what market it is, depending on what year it is, depending on what the reason is. And so we are trying to provide sort of a choose your own adventure set of prompts and ways to start the conversation and really tell you how we're thinking about this, as well as how the rest of the process works. When will the determination be made? What will the documentation? How much of this information will be public? Will we be able to contest it? So all of that is included in this guidance. Next. So I'm going to walk through each of the sections at a pretty high level, and then we'll stop for questions as well. So the first section talks about what is determining reasonableness, and that's a jargony term. I think if anyone has a better way to say that, I'm very open to suggestions here. The team's gone back and forth on some ways to talk about this, but basically what is determining reasonableness? And we are proposing determining reasonableness is the process that OHA and the payer or provider organization goes through to review and understand the excess cost growth and the factors causing the excess cost growth. That process happens before OHA determines whether or not the payer or provider's cost growth is for a good reason. And again, if a payer or provider has indeterminate cost growth, we wouldn't even be getting to this process. So if we do the statistical testing and say, all right, for this measurement period, you've met the cost growth target, this process doesn't happen. If we get to the data and do the statistical testing and say it's indeterminate, there was just too much noise in the data, we can't say for certain whether or not this payer or provider exceeded the cost growth target, none of this would happen. The funnel stops there, and this determining reasonableness process is not even entered into. So just keep that in mind, that not everyone goes through this process every year. And in the guidance document, we actually went back and looked at the data from last year's report and said, if this had been in place, if accountability applied, how many of the payers and provider organizations for each market would have been part of the determining reasonableness process. So you can actually see how that breakdown shakes out. Next. Section 1 also starts listing out those good reasons for exceeding the cost growth target. Again, as we shared, this is not an exhaustive list of reasons. This may be added to over time. And Elizabeth, I did see your comment about when and how you add to the list. I think that's a really great piece of feedback for us to add some clarification around. It's not currently clear. I think we are assuming that as we go into these conversations with payers and providers, that things will come up. There will be key themes each year as well as individual circumstances. And so it may be that something comes up in those conversations and then we say, yep, adding it to the list. So I don't know that it will ever be, this is the one window of opportunity where you can request something to be added to the list, but we'll definitely add some language to reflect that. James.
Yeah, I think that's a real important point. James Powell with Salem Health. Just for maybe you can provide a bit more clarification. So obviously we haven't done this exercise before as a state. And so of most things we've not done before, potentially we're all going to learn a tremendous amount. And I can't tell if these 8 reasons that are listed kind of at the start of each year, these are the 8 reasons. And if there's a reason outside of these 8, it's not included. Or
yeah,
number two in the rule does say, but is not limited to. So potentially there could be other reasons that are considered during the process. That's kind of clarification. It'd be useful to clarify that in the draft rule as well. Thanks.
Yep, we can do that. And I think, let me just state for the record that the list is not fixed at the beginning of the year and then changes only apply to a future year. If something comes up during that year, it would be considered a good reason for that year and sort of decided live. Kristen.
Good afternoon. Thank you for convening us. I know this has been a lot of work and a long time coming, so thank you. I was actually prepared to kind of like dig in on the rule a little bit because a lot of the themes that I think that I'll add to the conversation are throughout this sub-regulatory. So I'll put it out there one time and then just know it applies. And this came up in the chat. I think specifically around 2045 and total compensation for frontline workers, you know, that was carefully negotiated as a part of a larger package during the session in 2023. That language was purposefully not even put in the section around reasonableness. And there was clear language that providers shall annually provide that to OHA and would be part of actually determining the cost growth. So the idea there was that we would not have to defend as providers that workforce growth. It would be determined prior to then us having to defend it from like a reasonableness process perspective. So just wanted to put that out there, and it would apply to almost every page in the sub-regulatory document, and then probably require a new section and rule to clarify how that process would actually work.
Yeah, and Kristen, I do want to talk about that because I'm seeing a lot of questions about 2045. So I'm going to do a quick detour over to that. I think that was definitely some of the conversation during legislative session, that there would be a standard report and this would be a new data collection measure that OHA would begin collecting frontline workforce costs across the health system. There was a lot of concern from some of you, from others, that that's a new burdensome reporting requirement and that not everyone was sort of excited about that. So what we are proposing, what you'll see in the sub-regulatory guidance, is that this is opt-in, that there will be a standard reporting template, but that we're not going to issue and create a new mandatory data collection, data submission process for all providers. If a if a provider organization wants to come into the conversation and say, I believe the reason I've exceeded the cost growth target this year is because my frontline workforce costs, then there's a data submission process, and that's part of it. But not every organization exceeds the target every year. And again, given that burden of the creating new data collection, we are proposing not starting there. Would really love your comment, RAC members, on this, and particularly comments on this in writing about some of the ways that that could happen. And I think I want to also just recognize that 2045 really had a lot of hospital engagement around it, hospital and health system engagement, but the way that the statute is written says all providers in the cost growth target program. So if we think back to that slide that Zachary shared with the list of 51 provider organizations, we're talking about some FQHCs, we're talking about some primary care and pediatric groups as well. And so I think there's a mixed experience in terms of creating new mandatory data collection, and we want to balance those needs.
Can I just do one quick follow-up to that? I think the optional reporting, if that's the direction and that's what's important to us, some providers, is great. I think the where in the process though is a big concern, because it was the intent that those dollars would be backed out before there was any assumption that we had exceeded the cost growth. So
yeah,
I'll
please
put it all in.
share that in writing, and I think we can talk more about that, and our team will take that back. There are some technical difficulties with backing out the costs that have led to our proposal, but send us a comment. Andrea.
Hi, can you all hear me?
Yes.
Okay, yeah, I want to largely echo Kristen's comments and say, you know, we too appreciate the sensitivity around the reporting burden, but you know, this isn't. It was never intended to be an affirmative defense. It was intended to be part of the calculation of cost growth. So just want to echo, you know, finding a way forward to make sure that the rules reflect that.
Understood. And I think, again, encourage your comment on that, especially anything that from your perspective on the legislative intent. I think there were some conversations about this. The way that the statute is written, I think we believe we have some flexibility here, but we'd like to hear your perspectives. That's this process right now. Okay, so I want to come back to this list and keep walking through the document. One thing that I want to flag that we've added that's new on this list that has not been sort of in writing before this draft came out, although we've certainly had a lot of conversations with you, individual payers and providers, about this. We are proposing sort of officially putting high cost outliers on the list of good reasons. So we know, especially for smaller organizations, that one really sick kid can make the difference between meeting the cost growth target or not. And so we would like to put this on the list and have it be part of that formal umbrella of good reasons. And again, definitions for how we do that. There's some of that is proposed in the guidance document, open to feedback about how we do that. But we've heard from a lot of you and from consumer advocates very reasonably that concerns about access to care, not wanting payers and providers to deny coverage or to not accept a patient because then they'd be responsible for their healthcare costs, which might cause them to exceed the target. And so we really wanted to be clear about this up front. I also want to say that in several other states with cost growth target programs, they exclude high cost outliers from their measurement. Oregon is not doing that. We feel it's really important to reflect the true cost of care and not exclude from the data, but that we want to understand and not create that barrier to access to care. So codifying them on the list of good reasons. Matt.
Yeah, thank you. One of the things that I struggle with is that as well-intentioned as all of this is, much of the ideas around cost are also predicated on a system prior to the pandemic and the post-pandemic workforce challenges. In addition to, where on here do we have a recognition of the ongoing burden of patients that can't be discharged? And those discharge challenges are related to the state's inability to respond on APD, mental health, guardianship. And so in some of these cases, like, we have our own not-for-profit that we help funded with our community to deal with guardianship and work around. So there's also this sense that much of the cost assessment prior to today was predicated on a smooth transition of care to other settings after acute care services. That also belies the real day-to-day experience of insurers also denying care and not being accepted by post-acute providers. And so we have patients taking up capacity in the hospital, costing not just money, but creating access challenges. And we can provide that data, but I feel like without a recognition that there is a real systemic problem throughout the state and throughout the nation, really, of smooth post-acute transitions, I feel like we're also missing a really big piece that, as much as we try to optimize that, there are many barriers out of our control in that particular area.
Thanks for that, Matt. I think that the way I've been thinking about this is, especially the discharge or the step down issues, they're sort of under the umbrella of the pandemic effects. I think it's possible that we could add some additional clarity around that. And as we build out that definition, and I'd welcome any additional input you have on how to best reflect that as part of this list of reasons. Eric?
Thank you, Sarah. I just want to state, going back to your previous comments around high cost outliers, I think we as an organization would very much support codifying high cost outliers into the rule, or the sub-regulatory guidance, pardon me, so that we can recognize that. I think one of the key parts of that is we will need help from the Oregon Health Authority in regards to identifying those high cost outliers. And by that, I mean the interoperability of electronic health record systems is not universal in this state. I understand that most are on Epic, and but even those instances of Epic are not entirely interoperable with each other. So it is very clear that a primary care physician could have a patient that is accessing some kind of high-level care, and that primary care physician may not know that patient has accessed that care. They may not know that patient has ended up in the hospital, and if they didn't know they ended up in the hospital, they may not know the care. They may not be directing that care that the patient is receiving because it's being directed by a hospitalist or some other acute care specialist. And so I think it's important that we do add it to codify it in there, and that we do work with the Oregon Health Authority and the payers, et cetera, to be able to identify at the patient level who those patients are, so that we can identify them and use them not just as an affirmative defense in the case of reasonableness, but also use it as a learning to understand how we can work toward the goals of the cost growth program.
Thanks, Eric. I think when we get to section 3 in a second, there are some places where we're starting to spell out sort of examples, potential questions, potential analyses. And I think a lot of what you're saying there could potentially fit in that or be an addition or an expansion of that. If there are other places where payers or providers believe it would be helpful to have OHA's assistance in some of those calculations or analyses, or if we are proposing, hey, payer or provider, you should bring this data to this conversation, and you're going to say there's no possible way we could do that, that would be very helpful feedback as well. Okay, I want to keep moving just through a few more slides and then come back to the broader conversation. So next slide, please. Section 2 of the guidance document, again, matching the rules, is all about the process. So when does this process happen? It happens after the data collection and validation, but prior to the publication of the report and the public hearing. We talk about who participates, and really this is a place where we have a lot of flexibility in terms of who should attend. And I want to recognize some nuances to the Oregon system here. So we have a couple of organizations that are both a payer and a provider, or are both a payer and a provider under the same parent company. We are proposing leaving it all to you, to those organizations, about how to participate. And if a payer and provider, Kaiser, I'm going to pick on you for a second. If you want to come to this to OHA as part of the determining reasonable process and say, we actually think we need to have the payer and the provider side of the conversation together in the same room with all the teams, we would be open to that. On the flip side, if you wanted to come and say, actually, the payer and provider conversation should be totally separate for reasons, we're open to that as well. So you'll see there's a lot of flexibility about who should attend those conversations and how participation works. Another thing that we're putting out there is if organizations, payers and providers want to bring consultants in, if payers and providers, or payers or providers want to do any of these meetings in conjunction with each other, we would be open to that. Certainly there's confidentiality concerns, but we know, particularly on the pediatric side, there's been a lot of interest in having these collective conversations because the challenges are really similar. And so we are proposing a process that would accommodate all of that at the payer or provider's request. This section also talks about how determining reasonableness is different from data validation. And going back to some of the comments in the chat a few minutes ago about attribution, we would deal with attribution during validation for the most part. So there is a validation process that is happening. We want to make sure that we all have confidence in the data and the conclusions of the data before we get into this determining reasonableness process. We also talk about how to prepare for that conversation, some suggested ideas. Again, that's something we've heard a lot of you asking for and wanted to try to start outlining expectations. We talk about documentation. We are proposing that for every year, for every payer and provider organization who goes through this process, OHA will submit or will provide sort of formal written documentation. So there will be a paper trail of, we had these conversations, these were the reasons, they were good or not, result. We're looking for feedback here in terms of what would be helpful in terms of that documentation. Also in terms of how much of that is public or not. Certainly we know that some of the information that might be shared in those conversations is sensitive. Could be trade secret, could be information that you don't necessarily want out there. So we want to think about what the right level of detail is for public reporting. And that could be very high level. In our annual report, we could say these 5 organizations exceeded the cost growth target. We met with them and it was determined that 4 of them had reasonable cost growth and 1 did not. It could stay as high level of that. Or those letters, those formal notices could be made public. So I think, again, looking for feedback on that and comfort levels with meeting our transparency there. And then finally, this section has information about a proposed appeals process. We are proposing that this decision, once OHA sort of issues that determination, that is appealable. And there is an appeals process laid out, and that's similar to how a lot of other OHA appeals processes work. We looked at examples from the Patient-Centered Primary Care Program, the School-Based Health Center Program, and the CCOs to look at that appeal structure. We also are proposing that after appeals, if there's an appeal and you are still not happy with the outcome, there's the option to go to a contested case hearing. So sort of an escalation of that appeals process, and that is all outlined as well. Section 3, next slide, please. Oh, Andrea, go ahead.
Thank you. So, as we've heard today and elsewhere, a lot of the reasonable causes for exceeding the cost growth target are really systemic. We heard about, for instance, hospital discharge challenges, staffing costs, things like that. And so it seems that there should be a process before individual entities get to the point of having to defend their cost growth, where OHA is undertaking an analysis of those kinds of factors. Not only is it a more accurate representation of what's driving costs throughout the healthcare system, but it's a more efficient use of time and resources. I would anticipate that the determining reasonable process is extremely time intensive and costly for these individual entities that will have to go through it. So it seems like, you know, we could be a little more efficient and mindful of our resources by undertaking that larger scale analysis before we get to that point. It's also what the statute contemplates. I mean, the statute says that annually the program shall, for providers and payers who exceed the target, analyze the cause for exceeding the healthcare cost growth target. And that's not really what I'm seeing so far in these documents, where it's entirely on the entity to defend themselves against this presumption that their cost growth was unreasonable.
Yeah, let me speak to that a little bit, because some of this is, I believe some of this is in the document and really open to your comments and ways we can strengthen this to make the intent clear. So yes, there are some places where OHA might be tracking something and looking at broad impacts and might make a determination across the board before any individual conversations happen with payers and providers. One example is what we saw with the pandemic. We saw the drop in utilization and the way that that rebound affected costs. That was across the board. We had a very similar conversation with almost every payer and provider as we went through the cycle. We weren't determining reasonableness, but we were, if determining reasonableness applied in this time period, what would have happened? And I think there are some places where we could make those blanket determinations. The team here really tracks some of those statewide trends, national trends, and factors that are affecting things. And so it's not impossible that that would happen. I think I want to be a little candid to some of the tension that I think might be in the comments here of we have heard over the last 12 months or so, a real desire for a formula. For OHA will do these 5 calculations, and then there will be a clear answer. And I think I'm trying to hold the line where I don't know that that's going to be possible. I think it could be that there is just some new blockbuster drug that we know every payer paid for, and we could excuse all cost growth. In the data validation conversations that happen before we get to this determining reasonableness process, a lot of that is surfaced. And it is very possible that we might have that opportunity to say, all right, any cost growth stemming from this new drug is good to go. Not going to worry about that. That doesn't mean that there wouldn't still be a need for the determining reasonableness conversations for some payers or providers for some lines of business. So sorry, trying to split the difference. Welcome comments on how to better clarify that intent and OHA's role before we get to this process. I think that would be something we're really open to expanding, but with a reasonable expectation that I don't see a world in which no payers and providers ever have to go through this process. Eric.
So can you clarify then, so the process that we're in now, so we received our reports from you all last week, and we're beginning to set up the meetings with you all. Is that the data validation process that we're in, or is that
Yes.
the determining reasonableness process that we're in?
Yes, that is data validation. So all provider organizations currently who have received a message from our team, you're in validation.
Understood. Thank you. I was unclear on that. Thank you.
Yeah. Yep. And this is messy. And we really tried to think about, like, is this stage 4? Like, how do we separate it? And it's kind of an artificial separation in some ways, but yes, data validation now. Okay. So section 3, and this is where all the detail is. So section 3 includes more information about that list. So the detailed description of each reason, talks about the sort of burden of proof, and makes it clear that OHA has the final decision for the determination. So next slide, I want to talk about how the details are laid out. Hang on just a second, Rick. Okay, so for each good reason, we have this table, which includes a more detailed description, and it includes several bullet points of may include and does not include. This is also intended to change over time. It is quite possible that we might find more things that should be added to these tables over time as we clarify direction. So acceptable reasons might not just be on that list of 8 or 9. They might be some of the sort of how do we define specific scenarios. One thing that I would love to get out of your public comment and your not public comment, your RAC comment and your feedback to us in writing is other specific scenarios. If you want to say, what about X? Would X be in or out? That is super helpful to us right now because we'll be able to continue to build out this table and clarify scenarios. So the example on the slide here is for changes in mandated benefits. For example, that would include required coverage. So any sort of legislative mandate, or if there's a federal eligibility expansion that results in changes in coverage, things like that. But let's say that a payer decides to bring on an optional benefit. It's more of a cover a cosmetic service, and that turns out to be high cost. That would not count as a change in mandated benefits. So we're trying to provide more examples about how we're thinking about each of these, but we think that this will really evolve based on your comments between now and the February meeting. And one more slide, next slide, and then I'll stop talking again. So this is an example of potential questions that OHA might ask. And so we have a list. Again, this is a starting place. We're open to expanding this, and we almost certainly will based on your scenarios, but these are the kinds of questions that we would want to bring into this conversation. So for example, when did the benefit change happen? When did it roll out? How was it communicated? What's your perspective on this? There is absolutely some subjective components as well as more analytic. How much of the overage of the cost growth target is accounted for by the spend on the new benefit? What is the specific cost impact? Was there anything that the payer could have done to influence the cost impact of the new benefit? Were there specific contracts that were more or less affected by the benefit? Were there any mitigating factors to the new benefit? So we sort of want to unpack a lot of the things that might be part of this. So it's not just, was there a covered benefit change, new mandated benefit change? Yes, no, but how did that actually show up? And then on the last slide, next slide in this section, we propose some suggested analysis or documentation that a payer might want to bring to the conversation about a change in covered benefits. So some of this is data that could be pulled. Some of it could be other documentation. Some of it might be something like a third-party consultant report that quantifies something. So we want to lay out, again, a non-exhaustive list of questions and analyses and options, trying to find that right balance between, we can't give you a concrete formula where if this, then good reason done, but think of how we're thinking about these conversations and how an organization could best prepare for them. Okay, I think Rick and then Paul and then Kristen.
Thank you, Sarah. Rick Blackwell with Pacific Source. My sense here with the coverage mandates is that it seems like if the legislature is acting to require fully insured plans to cover something in the commercial market, those would, on their face, just be a reason for cost growth, right? We'll have a per member per month cost for everyone that would utilize. I mean, even if you have only a certain percentage of folks that utilize the benefit, everyone will eventually see the impact cumulatively in their premium. So I wonder, and this kind of goes too with some of the other factors. I do wonder if some of these, if they're factors outside of our control, and if you've ever lobbied against a mandate, you'll know that a lot of times they're kind of outside of your control. Some of it just seems like if it exists, it should be a kind of a per se reasonable cause for cost growth.
I think, Rick, I want to make sure I understand your comment. So if the legislature mandates a new benefit for fully insured plans, yes, that is like top line why this reason is on the list. I think what maybe I'm hearing you say is that, and therefore the conversation doesn't need to go any deeper than that. And I think I might need some more information or more about what you're trying to convey there to fully track.
It may be better follow up in writing, so no problem.
Okay, thank you. Paul?
Thanks. Paul Harmon from Regents Blue Cross Blue Shield of Oregon. Just as we've reviewed this, and we'll follow up with written comments, several of these categories are more applicable to the providers, and particularly sort of the may include sections are often from the provider point of view, which great, fine. But since payers are also included, we'll have some suggestions on sort of the payer version of some of these challenges, and just wanted to highlight, at the moment, it looks like a gap on the may include.
Great. I think we would love that. I think making sure that these scenarios and these examples and potential analyses are teed up for both the payer and the provider side is super helpful. The one exception is frontline workforce costs. Right. House Bill 2045 specifically created a good reason for providers only. I think, please feel free to comment on that on the payer side, but that one is in statute as provider only at this point.
Yes, and I think that's where we will comment just because
Yep.
the
Understood.
claims are still there, even if they don't count in one specific calculation. Yeah.
Kristen.
Thank you. And thank you, Paul, for those comments. Mine is kind of thinking about it from the reporting side from a provider perspective. So this is when you talk about the burden of proof. And I think for us, and this has been a theme for several years, it's not only a burden of proof, it's a 2 to 3 year look back burden of proof, right? That we then need to bring to the table to be able to defend cost growth that is not current state, but past state. So we've talked about a couple of really good examples, I think, that lend to what I'm going to get at. And one of them is length of stay and delayed discharge that is out of our control. Another of them could be high cost utilizers. So because of the way in which we've built the program, right, providers do not have visibility fully into utilization, attribution. We're not seeing the claims information, we're kind of seeing aggregate information. At some point, we can kind of maybe work with different payers to understand certain outliers, but that takes a lot of process that currently doesn't exist. And so when it comes to defending ourselves, what I'd like to see is more trends towards us being able to use information that we do have accessible. So you're looking at operational costs, utilization changes, some of those trends that we have data available for. We will not be able to back out those costs directly to the way that the cost growth is calculated, though. So some of the things around how did that specific cost impact your cost growth, or how much of the overage would be contributed to something. It's just the way information in the data we have doesn't directly correlate to all of the methodology for how cost growth is actually determined. So that's why what I want to put out there. I don't have a solution, but maybe it's just some changes in terminology, or even separating reasonableness defense between a payer and a provider to be able to capture that there will be some nuance. So.
And Kristen, same thing that I shared a minute ago. I really would love any suggestions or clarifications on how to make it more relevant for payers and providers, with one maybe giant caveat. We are not measuring operational costs. And so there is some potential burden of proof, or at least burden of connection, to show how the operational costs inform the other costs. And that might be a little squishy, but I think at no point would it be reasonable to expect that providers only need to show their operational costs, and then that would be the end of the story. There does need to be a connection back to the measurement.
Yeah, so for instance, like a pharmaceutical cost, we might not be able to show the level of detail that a payer could, but we could show utilization of that pharmaceutical.
Yep.
Okay, something like that. That's what I'm getting.
And utilization is absolutely on the list, I think, for all of these in the guidance document. And if it's not, it should be. So let's talk about, call out where it's not. The other thing that I want to say, which maybe again could be, the intent could be clarified more. This could be really nuanced, where it's actually a conversation in this process between the payer and between a specific payer and a specific provider. So for example, say that we're only talking to a provider organization about their Medicare Advantage cost growth. So now we know which payers attributed Medicare Advantage lives to that provider. We know which payers Medicare Advantage patients attributed had the highest cost growth. And so now we've narrowed in on sort of who might need to be in that conversation. So there could be some opportunities, again, where we're trying to leave it flexible for joint participation in these conversations to get at the nuances and the interplay between the payer and the provider side. Okay, I think James, then Tim, then Nick.
Hi, James Powell, Salem Health. Hey, maybe the elephant in the room, particularly for providers, so we're primary care with a sole community hospital, is obviously the questions that are being asked. Why did the cost growth exceed this number? Incredibly complicated to answer. I know the state is using actuaries to come up with this. I think you used the word statistical confidence a number of times. So we're starting to look at this and try and think of what the reasons might be. We're probably going to engage actuaries ourselves to try and determine what's going on in this data that we're seeing once per year that the state owns. So we are going to come up with questions we need more information on the data. An example might be, from the previous slide, can you tell us what insurance plan benefits have changed? Because we're not an insurance company. We don't know what benefits have changed. And if patients are accessing care outside of our primary care and hospital because of change in benefit plans, we wouldn't know anything about that. Another question might be, for us, for a number of years, we're attributed 30,000 lives, but we have 60,000 lives in our panel. So which patients are you talking about is probably an important question to be able to say, why did we exceed the cost growth target? And so I think, just to finish, so I think the binary nature of your presumed unreasonable, unless you can convince us there's a reasonable reason, I think there's a third answer, which is there is insufficient information available to answer the question in an accurate and honest way. And I do think that this binary nature, I think there's room within the law to say, you know what, there is insufficient information available for this primary care provider to be able to answer the question. I think more than not, that's where we're going to end in this process, and that concerns me. Thanks.
Thanks, James. That's a really fascinating point. Thank you for making it, and we'll think about that. I do want to just make two, I guess, counterpoints or provide two more pieces of context for the process before this. And one is that we do and expect to continue to meet with the payers first. The data submission and validation happens with the payers before we get to the providers. And so we would expect that by the time we get to provider conversations and determining reasonableness, we would already have gone through and understood some of the payer perspective and already, for example, had a heads up that, hey, there was a benefit change. So I think it is a reasonable expectation that OHA is bringing some of that information forward through the conversations, and we can clarify that. Second, about the attributed patients, and I know there were a number of comments in the chat about sort of who is attributed and not having a line of sight into that. We continue to offer through the data validation conversations, and I think it will become even more important when we get into determining reasonableness years, to help make connections between payers and providers, to actually share information. Where is that patient list? Who are these patients? What's the member list? And that's something we've encouraged. We've worked with a couple of payer provider combos over the last couple of years to help build that data sharing mechanism so that it's not a black box into who those attributed patients are. Okay, sorry, Tim.
Yeah, thanks, Sarah. I'm a bit new to this. As I said previously, I spent a lot of time this morning reading about this project, and something that really struck me is that there's a difference between percent growth and absolute cost. And what I mean by that is the sole focus of the cost growth target is to compare a provider's organization's performance to their own performance, to their own prior performance. And what that means is, as far as baseline cost could be very different in different organizations. So different organizations, even in the same city, have very different expectations for managing costs. And it seems like the OHA might have concern about rewarding organizations whose baseline expenses have been historically high and punishing organizations who have been efficient and now may have a higher percent growth.
Thanks, Tim. Nick?
Hi, thanks. So first, I just want to recognize that you're taking a very thoughtful approach to this, which is very complicated. And so just to mitigate some of my grumpy comments in the chat, so I just recognize that I know you're trying to do the right thing and manage this as perfectly as possible. And this is a somewhat half-baked idea, but I wonder, I think one of the things that gives me heartburn as a PCP is the kind of the assumption of the PCP's influence in driving utilization and driving care, especially with kind of PPO plans and not requiring referrals. A lot of patients can go wherever they want, right? Without necessarily, we're not in a strict, tight HMO model across the board anymore. And so I don't know if there's a way to factor that in terms of the plans. Some of plan design pieces that have a significant impact on, that often have an impact on utilization, and especially have an impact on the PCP, who is ultimately in this model. And I'm not trying to, I understand we're not here to relitigate the model, but just in terms of thinking about for today's discussion of like, what are those exceptions? Is there like a conversion factor somewhere on like, I don't know if there's like a conversion factor of like, for the number of patients attributed to PCP, how many of them are in a PPO plan versus some other less, how plan design factors into this. Again, half-baked, I don't really have a fully, but there could almost be like an adjustment factor, almost like risk adjustment to plan design.
Thanks, Nick. I welcome maybe a slightly baked, more baked thought and comment if you have one. Otherwise, I think point taken. Plan design is different. Okay, I know we're at just about time for public comment. I want to hand it back to Zachary to wrap up. Matt, is your comment real quick or question?
Real quick. Well, no, we'll submit in writing. I do want to say I am concerned that there's like a lot of takes I'm hearing in this process, and we still do have challenges like I put in the chat. I think OHA did some reporting on the percentage of low value care. I think we're focusing on some elements that obviously, as I were very concerned, that's appropriate, but I think there's also what I am concerned about is the nature of the conversation should include some of those other cost drivers that I hope we really do get to talk about. So thank you.
Right, Zachary.
Yeah, thanks everyone. Great input. We really appreciate it. Geronimo, do me a favor and go to advance 2 slides, please. Oh, sorry, back one. Sorry, I thought you were on a different one. So just FYI, in case you haven't seen it yet, we do have proposed rule language published. Today, we broadly, as Sarah mentioned, went over the sub-regulatory guidance document, but again, because that has some examples and it's really specific and it's helpful to kind of ground this conversation. But we also, obviously, we're welcoming input about that, and we're welcoming input about the rule language itself. Let's go to the next slide, and then the slide after that. So just a reminder, the verbal input we've heard today has been amazing and great. We'll keep that coming in future meetings, and we strongly advise written comments. It sounds like a lot of you are already planning on doing that. Some of you may have already even done that, so that's great. Keep that coming. Send that to our email address or to me. If you have any questions, reach out. Let's go to, yeah, go ahead.
Zachary, we have a question in the chat about timeline for submitting written comment.
Excellent. Yeah. So timeline for submitting comments. So February 14th. So Valentine's Day. We're hoping to get comments before February 14th so that we can build that into the next iteration. So the sooner the better. Please get that to us, but please aim for February 14th. Great question. Is there any quick question, Nick? Or that's from previous, I think that's your previous hand. Let's go to the next slide, and the slide after that. Let's go to the public comment slide. This is a public meeting, so I do want to open the floor, at least for a minute, for public comment. Any non-RAC members, so that is members of the public that have anything to say, please raise your hand if you do. Seeing none, I think we can kind of officially close the public comment period. Again, thank you all for this discussion. It's really helpful. So just a little plug here. So February, we're going to continue this conversation about draft criteria. We're also going to discuss performance improvement plans. We commit to sharing those materials at least a week ahead of time, if not more. And we will, to someone's point previously, we'll make it more apparent where the Zoom link is, so it's less difficult and less challenging to find. So we'll commit to that, and keep those comments coming. We're at time now, so again, thank you all for your participation, and we'll chat in February. More details to come via email. Thanks, everyone.
Thank you.
We'll wrap it there. Bye.
Thank you.